All right, so any questions from any of the previous material? I know you guys are studying diligently during your Thanksgiving break, and right? Okay, knew it. Great. So I'm sure you guys are very familiar with all that material. Anyway, so why am I talking about acute kidney injury? Why do you think that's important? Hmm?
The kidney, I don't know how to say it. It affects everything in the body.
Yes, the kidney absolutely affects a lot of things in the body. Absolutely. How do drugs affect the kidney? How do drugs affect the kidney? Well, yes, we know that a lot of drugs get eliminated through the kidneys. We know that a lot of drugs can have direct effects on the kidneys. You also find that a lot of drugs can have very negative effects directly on the kidney, right? So we're going to talk about different types of kidney injury that can be drug induced. We're going to talk about what to do with drugs when the kidney injury actually occurs, right? Because again, if you have a patient who's in the ICU and they're on a bunch of medications that are really eliminated, all of a sudden, they get septic, they get hypotensive, their kidneys aren't getting perfused, and they have kidney injury. You got to go back through and look at all their meds, right? You have to go back through and make sure that all those are being dosed appropriately, because otherwise you run into, well, certainly kidney failure, but like from the drugs not being cleared, toxicity, right? So this is where we run into things like vancomycin, gentamicin are super important to watch for. A lot of your carbapenems, penicillin, cephalosporins, those all have to be renally eliminated, have to be renally adjusted, lots of medications. So that's why it's really important to understand acute kidney injury, talk about the different types, and drugs can kind of interact with this. So basically we're going to call this an abrupt reduction in kidney function. We're going to talk a little bit about how we can kind of see this as evidence. So why do we look at creatinine? Anyone know why we use creatinine as a surrogate for renal function? It tells us the clearance. Why is creatinine a good marker? Why not use anything else? Why not glucose? But most glucose you filter through the kidneys. What happens to it? Gets reabsorbed. Absolutely, yeah. So that's not a really good marker, right? Because a lot of that gets reabsorbed. Similarly for protein, amino acids, you couldn't really measure that either because again, a lot of that gets reabsorbed unless you have like a patient who has kidney injury or like with glucose, you have a diabetic. Certainly, they're going to have a lot more glucose in the urine. Creatinine is really nice because it does not get reabsorbed and it does not get secreted to any appreciable amount. So what gets filtered in the kidneys, in the glomerulus, comes out of the urine. Okay. And so we can look at the blood levels as a surrogate for how well we're clearing that creatinine. So the lower our creatinine, what does that tell us about renal function? Better or worse? If you have a really low creatinine, well, if I have a really low creatinine, I'm clearing it very quickly, right? So I get rid of it. So that's a good kidney function. If I have a very high creatinine, that means I'm holding on to more of it. The kidneys are not really filtering it that well, right? So again, this is why we use it as a surrogate. It can be very useful for this. We also use our blood urea nitrogen. This can also give us some clues about how well that we're clearing a lot of the waste products in the blood. And then we also, this is a really important one to monitor, urine output. And so how do we measure that? Yeah, so if you have a catheter, you can look at a urine bag and see what they're all collecting there. Sometimes we'll have patients pee into a urinal, like if they don't have a catheter in. How would you do it for a baby? Yeah, you can weigh the diaper. Yeah, so you know what a dry diaper weighs, and then you can figure out what what the wet diaper weighs, and then basically figure out the density of urine, and then boom, you got your output essentially. So again, poor kidney function, your urine output should go down, right? Because again, if your kidneys are not functioning very well, you're not going to be producing urine very well. Thus, you're not going to have a lot of urine output. So again, these are things we're going to be monitoring for. And if you have big changes in any of these, it could be indicative of an issue with the kidney. Lots of morbidity, mortality associated with this. Because again, once the kidneys start to go, lots of other problems start to pop up from there. And the big thing here is you need to recognize it early because we don't have any good quick silver bullets in order to fix the kidneys, right? You can't reverse kidney injury. You can only stop whatever insult hopefully has caused the injury and then allow the kidneys time to kind of fix themselves if possible, right? So it's not as good as the liver as far as regenerative capabilities go, but it's okay. So in some cases you may have irreversible damage done, which you have chronic kidney disease at that point, and we might need to actually intervene and have some mechanical ways to replace the kidneys. How do we do that? Dialysis, yeah. So there's different types of dialysis. We'll mention those briefly here, just a few minutes. So when we have a patient with acute kidney injury, we're going to be monitoring their hemodynamic status, meaning look at the heart rate, look at the blood pressure. What do you think someone who has like kidney failure, what do you think their blood pressure does? Go up or down? Yeah, it should go up, right? Because you're holding on to a lot more fluids, right? So that intravascular volume's higher, so that increases the pressure. So that's one thing you might look at. We also want to look at minimizing nephrotoxins. So if you have a patient who's on drugs that we know cause direct kidney injury, like we want to try to get those off of the profile as best we can, try to minimize that exposure. Also looking at blood pressure management, right? Because the higher the blood pressure, what does that do to the kidneys, especially chronically? Yeah, higher renal pressure. What does that do to the glomerulus over time? Damage. Yeah, they don't like to have the high pressure there, right? That's why people who have chronic hypertension tend to have chronic kidney disease that develops over time. Just that high pressure just shreds that glomerulus. It's not very effective anymore at really filtering. So that's a big thing. Make sure keeping the blood pressure in check. Looking at fluid balance. So obviously patients who have kidney injury, they're going to be holding on to more fluid. So that may affect things like our fluids that we're going to administer to the patient, right? So you're looking at your inputs and your outputs. If their outputs goes down, you also have to make sure your inputs go down as well, because otherwise what could happen? Not necessarily. Where does fluid like to accumulate if you got too much that you're holding on to? Yes, maybe some of the abdomen, so especially at liver patients, they tend to get like ascites that develops. Where else could it go? To the limb, the extremities, right? So you can see pitting edema happen, the CHF patients. Where else is it going to go? The lungs, right? So pulmonary edema could be another big thing you can see there. So, like when you're doing an exam on a patient, you listen to that really kind of junky sounding lungs, like that could be a sign of fluid buildup, and you may need to do something to try to get rid of that fluid, right? So there's things you need to consider. And also looking at electrolytes. So electrolytes tend to take they kind of go out of whack when you have patients with acute kidney injury. What type of electrolyte abnormalities do you think you could see? Yeah, what happens to potassium? Do you think it'd be high or low? Yeah, generally high. Yeah, so you're generally holding on to more potassium. What do you think about sodium? Yeah, so you tend to hold on to a lot of things, right? So calcium you may hold on to, you may get hypercalcemia, you may see phosphate levels go up. So lots of different things can happen with that, and you need to monitor for that, because obviously potassium gets really out of whack. You can see cardiac disturbances. If your sodium goes out of whack, you can see neurologic issues that can pop up. Lots of problems that will come about from that. So there's different criteria. I'm not going to have you, stratify patients what type of kidney injury they're having, but there's different ones, like there's rifle criteria. Typically what they're looking at, though, is looking at changes in serum creatinine. So for instance, if it increases by 50% over a very short period of time, that could be indicative of kidney injury. Or if their GFR, which you guys remember how we calculate that? I think we talked about it at one point. Like glomerular filtration rate. You could. So you could do a 24-hour urine collection, right, to try to figure that out. What's another way we could do it? Remember that formula we did to get creatinine clearance? Like Cockcroft-Gault equation. That's a big one. That's one we use for a lot of our adult patients. We use creatinine clearance as a surrogate for our glomerular filtration rate, because again, creatinine doesn't really get absorbed or excreted very well in the kidneys, so that gives us a pretty good idea of how well we're actually clearing that, how much we're actually filtering it. So you're looking at the actual GFR and seeing that changes by, say, greater than 25%, or if your urine output goes less than. And in general, if you're looking at like an adult patient, 1 ml per kilo per hour is generally considered to be pretty good urine output. If it's like, say between 0.5 and 1 mLs per kilo per hour, that's usually pretty good. For kids, if it's greater than 1, that's great as far as urine output goes. But you can see here, if it drops below 0.05 or 0.5 mLs per kilo per hour for greater than 6 hours, that could be indicative they're not really clearing or producing and clearing that urine very well, right? So those are all kind of signs of this injury occurring. All the way up from having kind of risk, obviously as the changes get bigger, having more injury, and then failure, and then obviously if you have complete loss of function, you become anuric. You need to get rid of those waste products. You need to get rid of those electrolytes. And this is where we can do things like renal replacement therapy. To see RRTS, what I'm referring to, where they have to require a dialysis machine basically to clear the blood for them, right? And you found end-stage kidney disease. So here's another one called AKIN, Acute Kidney Injury Network criteria. And again, you notice very similar criteria here. Increase in serum creatinine, decreases urine output, decreases in creatinine clearance are the big ones. Anyone know what like a normal creatinine clearance is? 60 would be okay. Yeah, you usually think like 100, 125 mLs per minute, usually considered to be a good creatinine clearance. We'll see that there's different gradations of chronic kidney disease based on how low their creatinine clearance actually gets. So as it gets down to 60, as it gets down to 30 to 15 to 0, you're going to see very different ability for the kidneys to actually clear drugs and things like that. And that's where a lot of our renal dose adjustment comes from, is what their creatinine clearance is, and then kind of link that back up with the dosage we're going to administer. So looking at the different types you can get, you can see here that there's community-acquired acute kidney injury, not super common. You don't see it happen very, very often. Usually it's a kind of a single cause, but it could be due to things like sepsis, could be due to infection, different things like that. When the more important ones that we're really concerned about are going to be our hospital acquired and ICU acquired. These tend to have much higher incidences and tend to be multifactorial, so kind of multiple things are going on. So imagine you have an ICU patient who is septic, and septic patients, usually their blood pressure does what? Go up or down? Usually goes down. They get hypotensive, right? So if I'm hypotensive and I'm in preferentially, where does the body want to send blood to? What two organs? Heart and the head, right? So kidneys, they can kind of take a backseat, even though they're very important, but they're very metabolically active. So they require a lot of oxygen in order to keep all this energy, all these pumps working appropriately. So that takes a hit, right? So they get less oxygen being delivered in that case of sepsis. And what do you think happens then? Not enough oxygen getting to the kidneys? They're hypoxic. Injury occurs, right? So it can be one issue, and then all of a sudden we're giving nephrotoxic drugs on top of that. You can see how it can be multifactorial kind of thing, because how do you treat sepsis? Antibiotics, right? And so you're giving them pressors as well, right? Vasopressors like epinephrine, and that clamps down on those vessels too to decrease kidney blood flow. So you can see these kind of multiple factors here that all can kind of snowball into having patients develop these kidney injuries. So you have to be careful. You have to think about the patient kind of holistically to figure out like what else is going on here and try to identify what causes you can try to reverse if possible or just get rid of completely. So we're going to see that the management is going to be dictated basically based on the etiology of the acute kidney injury. So if you guys cover like pre-renal, intrinsic, and post-renal kidney injury. Okay, so what's pre-renal? How would you describe that to a patient?
Above the ureters, right?
Okay. Well, we know it's pre-renal, right? So that's already telling us before the kidneys. So think about like you're not really able to deliver enough blood and oxygen to the kidneys itself, right? So this is where you think a lot of it is due to decreased perfusion. And this is kind of an acute thing that can happen here, but generally you're going to have undamaged parenchymal tissue, right? So imagine that patient who is septic and they're hypotensive and they're not perfusing the kidneys very well. That's considered to be a pre-renal. What if you had a patient who was like abusing a lot of diuretics? Say they were taking loop diuretics so they wanted to lose weight, right? That depletes intravascular volume. That volume is not going to get shuttled to the kidneys like it should, and thus, again, they have a pre-renal kidney injury, okay? How do you fix that, do you think? Yeah, so maybe stop the diuretics. That could be one obvious thing, right? Fluid replacement, that's absolutely it, right? So again, if they have been bleeding a lot and they're hypovolemic because of that, give them more blood, right? If they are hypovolemic because they're dehydrated, give them fluids, right? That's the biggest thing you can do to fix these patients. And you want to do that quickly because, again, the longer you hypoperfuse the kidneys, the more ischemic they get, the more likely you are to have this intrinsic damage. This is where we actually have structural damage done in the kidney. Could be due to ischemia or could be other toxic insults. This is where we start to get into the medications that can cause this, right? We've already seen how diuretics can affect that, and now you're starting to see the intrinsic damage that can happen from things like chemo agents we'll talk about next semester, things like gentamicin, things like vancomycin, and other drugs like that that can be directly nephrotoxic. Now imagine, what if I gave a patient, the NSAIDs are associated with kidney injury. Why do you think that is? We talked about that mechanism before. Remember that efferent and the afferent arteriole, right? So you had the afferent arteriole coming in. Remember what kept that open? Prostaglandins, right? That's vasodilatory. If I give an NSAID, inhibit cyclooxygenase, all of a sudden prostaglandins are gone, that clamps down, right? So now I have less blood flow getting to the kidneys. What type of kidney injury do you think that is? It's pre-renal, right? So that can be one thing where you can see, okay, patients dehydrated, maybe they're on a loop diuretic, and now they're on NSAID too. You can see how there can be multiple drugs can influence this, and both of those can be pre-renal. But again, as the damage goes on, or if you have direct damage on the kidneys, this is where you get more intrinsic. This less common one is going to be post-renal, and this is usually due to obstruction. How do you think drugs could cause an obstruction downstream of the kidney? Or what could be any cause for a post-renal obstruction? Good, crystallization. So you think kidney stones, right? You think nephrolithiasis, it can happen there. Drugs can do that too, right? So we mentioned, talk about methotrexate, right? That is one that can actually do that, especially if we give really high doses for cancer. You can see this with acyclovir. You guys know what we use acyclovir for? Yeah, viral causes like herpes usually is one of the big ones, so HSV. So that's another big one where you can see that crystallization that can occur there. And so kind of a post-renal where you're kind of blocking or obstructing the flow of urine. So again, not as common, but it could be something to consider depending on the medications that they're on. So again, looking at the prerenal, this is going to be everything kind of before the kidney. The actual intrinsic kidney injury obviously can be kind of broken down into whether it's kind of glomerular injury, tubular interstitial, or the tubular obstruction, where you can see issues there with intrinsic causes. And then later on you have post-renal AKI. Even like patients have really severe BPH or really bad prostatic hyperplasia, that could be another cause for obstructive kidney injury as well, right? Because if it's clamping down so hard in the urethra, that could be another potential cause there. So, and you can break it down basically by looking at the history, right? So you're going to evaluate your patient. You're going to be looking at things like urinalysis. You're going to be looking at things like their physical exam, like do they seem to be fluid depleted? Like how could you tell someone's really dehydrated? Yeah, so the turgor of the skin is going to be diminished, right? So it'll just kind of seem dry. What else do you look at? Orthostatic, yeah, blood pressure, certainly that would be abnormal. Yeah, so that'll be going along with the urinalysis we'll be looking at as well. But just on the physical exam, how could you tell them kids?
No tears when you press.
Okay, yes, sure, no tears. Also, they have a hole in their head, right? So that fontanelle can be sunken in. That could be another thing you could look at. So there's lots of ways you can tell if someone's dehydrated, right? Just based on physical exam. Certainly other things we'll go into. So laboratory testing is really important as well. Looking at a basic metabolic panel to look at their electrolytes and their creatinine and the BUNs, all can be really important here as well. Again, I'm not going to get specific into analyzing the urinalysis because again, you'll learn that elsewhere. But I'm trying to getting into how do you identify this kidney injury and then what can we do about it as far as like medications go is what we're going to look at here. And certainly, there's lots of causes here, so I'm not going to go into all of this, but just know that we'll cover some of these as it relates back to drugs in just a little bit. So again, looking at community-acquired AKI, usually it's going to be secondary to renal hypoperfusion. We see this a lot, especially in patients with like really significant gastroenteritis, a lot of vomiting, dehydration, diarrhea. In the summertime, imagine patients who are getting out there and when it's routinely above 100 degrees out there, it's super humid. They may not be drinking water like they should. They get dehydrated. They can have this occur. And the medications. So I mentioned the diuretics, also the ACE inhibitors. How do you think that would cause kind of a hyperperfusion of the kidneys? I mentioned NSAIDs would be working on that afferent arterial. How would this work on the efferent arterial? Ang2 normally constricts it, but if I give an ACE inhibitor, yeah, it'll dilate, right? So then you lose that pressure. You're kind of like taking that kink out of the hose essentially, and so that filtration pressure goes down, and so they can't really clear. They're not really getting that pressure to filtrate the blood coming through there. So that could be one thing you can see there. So really, that's why you worry about kidney injury with like ACE inhibitors with NSAIDs. Kind of that same mechanism, just on the different sides of the glomerulus there. And so then you'll see with a lot of the hospital and ICU acute kidney injury, a lot of it's intrinsic. Usually acute tubular necrosis is the more common thing you're going to run into. So risk is also going to go up with several factors. So things like septic shock, if there are older patients, nephrotoxic drugs. What do you think surgery? They had a particularly bloody surgery. Maybe they lost a lot of intravascular volume. That could be one reason. They're kind of in a critically stressed state. Lots of reasons for that. Trauma, obviously, due to the blood loss and whatnot. African American patients tend to be at a little bit higher risk as well, so that's one thing to consider. And then, obviously, any previous history of acute kidney injury could also obviously put them at risk for future kidney injury. So, we talked about this. So again, decreased intravascular volume could be due to any reason for that. So it could be hemorrhage, GI losses, whatever happens to be. Usually with sepsis, you have what we call kind of third spacing of fluids. Anyone heard of that term before? What does that mean? Yeah, you have very leaky capillaries, and you see that a lot with sepsis when you have kind of this kind of body-wide inflammatory response. We have a lot of fluids leaking out to the interstitial space, and so it's not staying in the intravascular space to perfuse the organs and whatnot. So that could be one big thing you see there with sepsis. Sometimes you can have hypoperfusion without hypotension, and that can be related back to renal artery occlusion. That's a little bit more of a rare one than kind of outside of our scope here. Usually you're going to see a lot of compensatory responses to this, right? So we already talked a lot about this, especially with drugs that induce hypotension. So like antihypertensive drugs, we see a lot of reflex responses here. So this is where like your sympathetic nervous system kicks in, renin-angiotensin, antidiuretic hormone, all of this, their thirst response is being kicked up. The kidneys are hopefully holding on to more fluids by holding on to more salt. All that's going to be these kind of compensatory responses, but there's a limit to all of that. There's a limit to how much homeostasis our body can really institute, and so that gets overwhelmed, and thus they hyperperfuse the kidneys still. So, Looking at kind of a functional acute kidney injury, you can see this with ACE inhibitors and ARBs. So imagine like heart failure patients, they tend to hold on to a lot of fluids anyway due to poor cardiac output. They tend to have a lot of kind of venous, backflow of a lot of blood and things like that. So they can see those issues happen there. Think about NSAIDs with patients with chronic kidney disease. They oftentimes rely on those prostaglandins to keep that afferent arteria open. So if they lose that, all of a sudden all that blood flow is going to be diminished pretty significantly. You see kidney injury happen with that. And I mentioned the vasopressors. So things like epinephrine, things like dopamine, as they squeeze down those vessels, again, the body's going to preferentially try to get blood to the heart and the head. So if you lose it to the kidneys, again, that can cause the injury there. That's one of those things where it's kind of a double-edged sword because you have a septic patient who's coming in, you give them all these antibiotics, which can be nephrotoxic. You're getting these vasopressors, which are going to hurt the kidneys, but if they don't have any blood pressure, guess what? They're going to die anyway, right? So it's one of those things where it's like sometimes you have to say, well, kidneys, sorry to do this to you, but we got to keep the patient alive, right? We can fix you later. We have machines that can replace you anyway. We try to be nice to our kidneys, but maybe that's why we got 2 of them anyway. Anyway, this intrinsic kidney injury is going to be more due to actual direct damage. This is where you see more kind of drug-induced direct causes of damage, like things like the glomeruli, the tubules, interstitium can all be damaged here. So we'll talk about a few drugs that will do that. So you can have potentially other causes. So things like large emboli that can occlude some of the renal arteries, but sometimes you'll see these smaller vessels get occluded too. But again, just keep in mind that patients with uncontrolled hypertension, chronic kidney disease can be one of the big things you run into. Is kind of a chronic complication of that because that high pressure is just going to cause further damage to the kidney. So always consider that. That's why we try to get their pressure under control. Again, looking at glomerular damage, pretty rare for the most part, but we'll talk a little bit more about glomerulonephritis later and some treatment for that. More often than not, you're going to see a lot of tubular damage, right? So this is where you're going to see either due to renal ischemia. So if you say you're in a hypoperfused state for a long period of time, that's where you can see that causing tubular damage. Other times you can see it due to toxins. So it could be due to things like myoglobin, hemoglobin, sometimes build up in the kidneys can cause this injury. Oftentimes this is where we'll see a lot of our drugs coming in here as well. So things like contrast agents. You guys know what we use that for? Yeah, if you use for medical imaging, so you think about like CT scans and things like that, we use those to look for like bleeds, or we'll look for all kinds of different things. That can be one thing that will hit the kidneys. We'll talk a lot about that extensively later on. And then like aminoglycosides. You guys remember some examples of aminoglycosides? Amikacin, gentamicin, tobramycin, right? So those are the big ones. So you worry about that. Again, they have a high oxygen demand. If you decrease that amount of oxygen getting to the kidneys, you're going to see that damage being done. Okay, next we'll see a lot of acute interstitial nephritis can also be a big issue, especially with medications, but you can also see things like autoimmune diseases can cause this, like lupus can be a really big one causing this kind of interstitial nephritis. Infections can do this. You'll generally see that if you can get this treated early, most of the time it's reversible, but in some cases if it were to go on for kind of a prolonged period of time, this is where you can see some irreversible damage being done. But all right, so looking at acute tubular necrosis, typically what we're going to see here as far as the actual how it occurs, you're going to see this ischemic injury. Again, half the time it's going to be about ischemic injury, cause a lot of necrosis and the apoptosis of the cells there. The problem that runs into in what you'll find sometimes with these patients is they can have urine production. They can still make their urine, but someone described it to me as the kidneys get dumb, to where they can't really regulate how well they're going to be filtering and reabsorbing a lot of solutes and whatnot that gets filtered initially at the glomerulus. So you can see issues where you're having a lot of fluid and electrolytes not being regulated appropriately due to this damage to these cells, these interstitial cells that aren't working functionally anymore. You can also see that urine flow can be obstructed. So like on the urinalysis, you see like a lot of casts that can be formed there. Guys familiar with casts? Yeah, so they're basically kind of almost molds of the tubule. They'll break off and you'll see that. So depending on what type of cast you'll see, it can be indicative of the type of injury you're going to have there. And typically this is not a very quick process. This can happen over hours to days in some cases. And the big thing you're going to see here is this kind of impaired urine concentration. So you're going to be spilling out a lot of electrolytes like magnesium and potassium. You're going to see decreased urine output occasionally, and then that reduced GFR. So we're going to hold on to that creatinine. You'll see that start to go up, and then if you remember, if you look back at that Klokroff-Gault equation, the serum creatinine was in the denominator. So as the serum creatinine gets higher, it's going to drive your creatinine clearance down, right? So anyway, once the insult's over, once you kind of get over whatever, you've DC'd whatever kind of offending agents caused this, or you've kind of corrected whatever disease state, some reversal and some return of renal function can occur, but it takes a long time, so weeks to months occasionally. They may need to be on intermittent dialysis in the meantime. It just depends on the degree of damage done. So anyway, again, post-renal is very, very rare for the most part. Oftentimes you can see things like bladder outlet obstruction. We'll talk about BPH and treatment of that in the next section, so we'll get to that a little bit later on. We'll talk about meds that can actually help to relax the prostate and allow for better flow through the ureter. We can also see it due to oxalate crystal depositions. That can be due to medications. So imagine things like acyclovir can do this, methotrexate. Anyone who has, again, being in here in Florida, we have a high amount of calcium in the water, and so we tend to see a lot more patients with nephrolithiasis because of that anyway. And just any kind of drug with poor urine solubility. So that's one thing you always want to worry about. Patients called crystalluria, that's what we're talking about with that. And then also, anyone ever heard of tumor lysis syndrome? So sometimes what you can have when you give chemotherapeutic agents, basically they will, especially for like leukemias and stuff. So like leukemia is basically what kind of cancer? All your white cells, right? So your white cells are going to be kind of rapidly dividing. If I lyse all those cells at the same time, they release all their contents, right? So if I give them, because again, that's a kind of very they're replicating in a very high degree, right? So again, you kill off all those cells with a cancer drug, they release all their contents, and sometimes things like uric acid and whatnot can actually clog up the kidneys after that occurs, and so that can be a very severe thing and cause kidney injury for those patients. We worry about that. We have actually a specific drug we'll talk about later on that we can use to actually treat that. But if you're a tumor lysis syndrome, that's specifically a thing, usually with leukemias and cancer treatment. Okay, so how would you see someone who had acute kidney injury? Oftentimes you're going to have things like decreased urine production, sometimes changes in color. Obviously, if it was due to things like myoglobin clogging the kidneys, secondary to rhabdomyolysis, what would the urine look like? It kind of looks like tea, almost like if you ever look at pictures of it, it looks just like iced tea or something like that. Obviously, if they're having any bleeding, would definitely not be a normal sign. You should check that out. Obviously, sudden weight gain, holding on to fluids, it can be indicative. And you need to really determine if it's kind of an acute issue, chronic, or acute on chronic. When I say acute on chronic, what do you think that means? Yeah, they have a chronic baseline problem. They can have some kind of insult that will kind of do an acute worsening, acute exacerbation of that. So kind of keep those in mind, because again, the acute person might have been previously healthy, had no issues, and they developed this kind of acutely, or it could just been kind of a chronic issue, or they're just chronic and they have kind of a sickness or illness or something like that will kind of make it worse. Usually it's a lot easier to determine if it's inpatient because you have a lot better monitoring of things like urine output or their creatinine. You're doing labs, you know exactly what medications are getting. Usually a lot easier to determine what the problem is, and usually we're the ones that did it to them in a lot of cases, especially in the course of medications. We're usually the ones that gave them that kidney injury in the first place. So anyway, when you're evaluating these patients, good questions to ask. So obviously you want to look for any chronic conditions. What's kind of a chronic cardiovascular / endocrine problem that can lead to kidney injury over time? Diabetes is a big one, right? So you want to figure out if they have a diabetic patient. That leads you to think more kind of a chronic kidney disease kind of picture. Get their med history. Again, how would you ask a patient, like, how do you ask them, like, well, about their medication history? What questions do you ask? Okay, what are you taking? What are you taking it for? Any other specific questions? Yeah, good. So ask about over the counter. Anything else? Herbal supplement. Ask about dietary herbal supplements. And again, you have to be very specific. I was actually just doing a sim earlier over with my other students, and it's one of those things where the guy who's running the mannequin, they were like, okay, do you have any chronic illnesses? And the guy's like, no, I don't know. And then they were like, well, okay, do you have diabetes? No. Do you have hypertension? No. Do you have COPD? Oh, yeah, I have COPD. Sometimes you have to ask these patients very specifically yes or no questions on each and every one of these things, because if you ask them a blunt, like, do you take any medications? They're like, no, I don't take any medications. Okay, do you take anything to get a headache? Oh, yeah, I take ibuprofen. Oh, yeah, I take aspirin for my heart. Sometimes they're not very great at answering your questions, right? No fault of their own. They're just not very medically literate in a lot of cases, so just think about this sort of thing. So next we'll look at any lab studies. It's really important to make sure if you have any kind of previous labs, look at those as well, because you want to look for trends. So if I have a patient who comes in, anyone know like a normal serum creatinine is? 0.6 to like say up to 1. Let's say, it depends on the lab you're looking at. They'll have different reference ranges, obviously, but let's say like 0.6 to 1, just for our purposes. So they come in, the creatinine's 2. Okay, that looks abnormal, but the question is that abnormal for them or is that normal for them, right? Because you could look back 6 months and they're like, oh yeah, I had another one done and it was actually 3. Okay, maybe their kidneys are actually getting a little bit better. So those are kind of the questions you need to look for in trends as far as what their creatinine is doing, if this is a chronic issue, acute on chronic, all those sorts of things. And obviously any kind of recreational drugs, a lot of times people do not want to own up to a lot of these things, but we've seen several kind of newer kind of these kind of amphetamine-like kind of drugs. Anyone ever heard of bath salts? Okay, right, so you at least heard of them. Hopefully no one's ever done them. I pray, I hope, because stuff's real bad. But there were some really bad ones that actually caused significant rhabdomyolysis, caused very significant hyperthermia. Several people died from that. But one of the big things you worry about with rhabdo is that myoglobin clogging of the kidneys. And so that could be a cause if they're having an acute kidney injury. Maybe they've done a whole ton of cocaine over the past weekend. That's what precipitated this, or amphetamines or something like that. These are important questions to try to get out of your patients. Okay. And again, look at trends whenever possible. So, looking at serum creatinine, just know there's limitations with using creatinine as far as using as just a single point to decide what kind of kidney function the patient has, right? This is going to vary greatly depending on, I'm sure we've kind of mentioned this before, but it varies on age, on gender, on muscle mass, on diet. So imagine if you have a patient who is, say you have a 70-year-old patient versus a 20-year-old patient who has more or less creatinine, or who has more creatinine, I guess. Who generally produce more, you think? Yeah, why the 20-year-old? They have more muscle mass. Yeah, exactly. They're well developed. They've not had any muscle wasting. They're probably still physically active. They probably have a lot more muscle, right? So then that's more muscle to produce creatinine. Okay. How about gender? Who do you think has more creatinine in general? Typically men, right? Because again, on a pound per pound basis, typically men have a higher percentage of muscle mass. There are exceptions to that. There's some very large female bodybuilders out there who could probably have very high creatinines, right? There's also some very men who have a lot of adipose tissue. They probably don't have as high creatinine. Again, it's going to be patient specific. Why do you think diet could affect this? Yeah, what happens if I go out and eat like 4 pounds of chicken? My creatinine's probably going to be high, right? Because again, that's all just muscle tissue. Versus someone who's a vegetarian, they might have very low creatinine in comparison. And then look at their hydration status. Obviously, they're dehydrated. What do you think that does to creatinine? Down or higher? Less fluid, so decreasing the volume, same amount of creatinine, gets concentrated, right? So that can actually go up. So it could be something, and we see this a lot with some of our CF patients, right? So cystic fibrosis patients over at Nemours, they'll come in and they'll be relatively dehydrated. Their creatinine will look high for them, especially because they're usually our frequent flyers. We see them very frequently, so we have trends on what their creatinine does. We'll give them a couple liters of fluid, check it again, and all of a sudden gets back down to normal, right? So once they get back to their normal hydration status, they're at a relatively normal creatinine level. So again, always consider the hydration status there. So, what do you think about amputations? What do you think that will do for us? So they have like a war vet, had his leg blown off in Afghanistan, less muscle mass, right? So you have to take that into account. I've had patients who've had amputations. You've had diabetic patients who have amputations due to their progression of disease. They may have a normal creatinine, even though they have very abnormal kidneys, right? And that's due to the fact they've had these amputations. They've lost a lot of that muscle mass. So again, that would falsely elevate my creatinine clearance. I would think it's falsely much better than what it actually is. So take that into account. The other thing was the serum creatinine. It takes time for it to build up, right? It takes time for it to get to steady state. It has a half-life just like every drug you would give to your patient, right? So it takes 1 to 2 days or so for it to really kind of catch up. So if you're looking at a patient's, say their basic metabolic panel, you're looking at their creatinine every day, you start to see it go up, chances are the actual kidney damage or whatever changes occurred happened about a day or two ago, right? So it takes time for that to build up. And so most often what we can actually do is look at other signs to give us an idea of kind of what their renal function is doing. So what do you think would be a much more immediate thing we could look at to detect their kidney function? That could also take time to build up too, right? Because again, as the change occurs, whatever happened, that takes time for those levels to re-equilibrate. You look at urine output, right? So the patient's going to be peeing pretty consistently, you might imagine. If that changes, that can be a very quick sign of something different. So when we do our monitoring, especially for patients on vancomycin, on aminoglycosides, one of the things we monitor is we look at urine output, we look at their creatinine, right? Because we're looking for trends in either. Usually urine output's a lot faster to be indicative of something going on. And so sometimes we'll even have our patients will, all of a sudden, it looks like it goes like from, say 1.5 mLs per kilo per minute down to like 0. And we're like, oh my gosh, what happened? They're anuric. And it's like, no, they're a teenager and they just don't like to pee into a urinal. They just went into the bathroom and peed, and then the nurse was like, what'd you do? And they're like, oh, I already flushed it. Now you don't have anything to monitor. So sometimes you're actually going off the number of voids they have as well. So you can say, okay, well, he peed 6 times today. Chances are he's not actually anuric. He's a teenager and didn't comply with our orders, right? Again, something you can run into depending on the type of patient you have. So, again, certain calculations can over or underestimate GFR. We said Cockcroft-Gault is the big one we use for a lot of our adult patients. Obviously, pediatric patients require a different calculation because they are, kids are not just little adults. They function very, very differently, so have different equations for that. Let's use what we call a Schwartz equation. Now this is just a sign, looking at their GFR, looking at serum creatinine, you kind of see if an injury were to happen right here, this insult, it would start to go down very immediately, right? So again, the kidneys are not functioning, they're not really filtering as well as they should, so that happens, but it takes time for that creatinine to really kind of get to a new steady state. So again, this is why you may be late in diagnosing a lot of this. They're looking at other things, they're looking at other kind of biomarkers that might give a faster indication of kidney injury, but again, it's not something we're using routinely. Creatinine is a very easy lab to get, it's on every single basic metabolic panel you get out there. So the biggest thing, if we can predict it, we can prevent it, right? So again, prevention is much worth a whole lot more than a cure, obviously. So if we can do things like aggressive hydration, we do this a lot for our chemo patients who are getting drugs that can precipitate in the kidneys or can cause a kidney injury. We give them aggressive hydration, give them lots of fluids. Typically, as long as their heart is good, as long as they have good ejection fraction, as long as they are able to clear fluid from the kidneys, you don't really have to worry about a ton of fluid buildup. It's only like your CHF patients, patients already pre-existing kidney disease, you worry about them holding on to fluids and getting edema or getting pulmonary edema, things like that, right? You want to avoid nephrotoxic meds whenever possible. It may not always be really ideal for your patient, but if you try to avoid them if you can. And then ideally, we like to screen and identify patients who are at risk, and then try to monitor it until that risk is kind of over. So look at some cases where you kind of short period of risk, and then try to have any preventative strategy where we can. Okay, so try to prevent it whenever possible. So hydration. So again, this is consistently shown to be the best benefit for our patients. So if you keep them hydrated, they have the best chances of avoiding acute kidney injury. And so we have different types of fluids. We have crystalloids and colloids. Anyone know the difference between the two? Crystalloids are just salts. They're just salt-based, right? So again, these are going to be things like your normal saline or your normazoline. If you want to, tell your patient, like they say, oh, I need my pain meds. You're like, I'm going to give you a liter of normazoline. It's going to make you feel great. That's what I like to tell people. Lactated ringers, they use this a lot in surgery, is also another thing you may see. Lactated ringers is kind of almost primarily just used in surgery. Everywhere else kind of uses normal saline for the most part. And this is going to be kind of the recommended agents because they're relatively cheap and they're also unlikely to cause side effects for the most part, right? And remember what percentage normal saline is of saline? Yeah, 0.9% sodium chloride, right? So again, there's half normal saline that's out there. There is quarter normal saline. There is 23.4% saline. There's 3% saline. You want 0.9. That is normal saline. It's going to be good for the majority of your patients, right? So if they're coming to the ER, they need some fluids, give them 0.9%, give them normal saline, right? Why is it normal saline? Why is it normal? You guys remember the tonicity of normal saline? We talked about this before, right? It's 154 milliequivalents of sodium. It's 154 milliequivalents per liter of chloride. Add that together is 308. So that's the tonicity. That's the osmolality of normal saline. What's the osmolality of normal human blood? It's around 300, right? 280 to 320 or so, somewhere in there. So again, because it's isotonic, you don't see a ton of fluid shift that happens here. Most of the fluid is going to stay right there in the intravascular space, and that's going to be good for our patients to keep them tanked up, keep them hydrated, okay? So that's why I like to use normal saline. You have other ones called colloids. These are going to be more starch-based or protein-based in some cases. This can include things like head of starch-based products or albumin. Obviously, we produce albumin already, in our bodies. It's very one of the more common serum proteins. We can give albumin as well, right? So sometimes we'll give this to patients who have a deficiency of albumin. Sometimes we'll give it in other cases where they're kind of missing proteins, and so we can use that occasionally. These tend to be more expensive, and actually some of them are associated with actually inducing kidney injury. So again, if you're going to hydrate a patient, give them a crystalloid. 9 times out of 10, actually 99 times out of 100, chances are you're going to give them normal saline. In special circumstances, you may give them things like albumin to replace volume, right? We use it a lot like in cardiac units and whatnot, but normal saline is usually the go-to, right? Okay. So I kind of mentioned this, so it just kind of gives you the idea. So when I say 0.9%, it just basically means 0.9 grams of sodium chloride per 100 mLs. And if you were to actually figure that out, you can see how it's very close to the serum osmolality of normal blood, right? Now keep in mind that dextrose, if I were to give D5W, which is typically a normal concentration of dextrose we would give in IV fluids, even though it's isotonic, even though it has 253 milliosmoles per liter, so it's close enough, it's what we call all free water. What do you think free water means? And like dextrose gets very quickly metabolized, it gets shuttled off into the cells, and so all that fluid's there, but there's nothing holding it in, right? There's no salt actually holding it in there, so it tends to accumulate out into the intravascular interstitial space, ends up going out to the cells, and so it's not really good for fluid replacement because not a lot of it stays in the vasculature. But by giving sodium chloride, you can keep it all right there, right? So we'll talk about intracellular fluid shifts and things like that a little bit later on, but just know that if you're doing volume replacement, then you want to go ahead and give normal saline typically, right? What do you think someone's heart rate does when they're hypovolemic? Usually increases, yeah. So usually tachycardic. So that could be another sign. If a patient coming into the ER, history of gastroenteritis, they're tachycardic, chances are they're dehydrated, right? They just need more fluids. That can be one thing you can monitor to see how well they are intravascularly repleted by looking at their heart rate, make sure it comes down to normal, roughly. Okay, so looking at prevention of acute kidney injury, so there's some things we'll say, well, what if we just increase urine flow? Perhaps that would just go ahead and keep our kidneys functioning. Let's give something like loop diuretics. This isn't actually found to be very helpful. So, can you remember any examples of loop diuretics? Lasix is a good one. So furosemide, any other ones? So bumetanide. There's torsemide is the other big one. There's ethacrenic acid, which you don't use too often, but occasionally you might use it. Not super useful. And then the other thing is if a patient has kidney injury and they're not really clearing the drug very well, they can see ototoxicity, right? So it can actually damage those cochlear cells, and we don't want to do that, right? So this is only good if you have patients who have a fluid overload. So they have really junky lungs and you think they have pulmonary edema, they have pitting edema in the extremities, like that's a good sign that, okay, let's give a loop diuretic to try to get rid of that. So occasionally you'll do that for like CHF patients, right? We talked about that not having mortality benefits, but it certainly has symptomatic benefits, right? So again, this is where loop diuretics can be very useful for that in those cases. Sometimes we can use vasodilators, and so dopamine, we mentioned that earlier, kind of mentioned as a vasopressor. Dopamine at lower doses actually causes dilation of the renal vessels and actually improve renal blood flow. And so sometimes you'll see dopamine being given at a low dose. If you give it at higher doses, that's where it starts to activate things like alpha and beta receptors, and so sometimes you'll see at higher doses being used as a vasopressor to treat hypotension, right? So that way it'll increase the dose, it'll increase cardiac output, increase systemic vascular resistance. Those are all good things. But if you use it at a lower dose, it's kind of good as a kidney blood flow. It kind of increases that. Another one called phenoldiprate we may use occasionally. These are not super consistent as far as causing benefits here. So again, not used routinely as a means of preventing acute kidney injury, but something you may see some occasionally. Some people feel if you give antioxidants, perhaps when you cause ischemic injury to the kidneys, that you're causing a lack of oxygen, you're causing this ischemia, you're causing these free radicals to form, these reactive oxygen species that tend to go around, that denature proteins, cause other cells to be damaged, and lead to further destruction of the cells. So say, well, let's give an antioxidant. Let's give something that can actually get rid of those free radicals. We'll neutralize them in that way. Hopefully you can kind of prevent damage. I'm sure most people are aware of vitamin C as being an antioxidant you can give. That's not really been found to be super useful, but again, it's low cost, and just maybe give them an orange, see how the kidneys do. We have IV forms as well, but again, good safety profile, so you don't have to worry about that too much. Another one we have is called N-acetylcysteine or Mucomyst. I'm sure you've used Mucomyst before, right? What do you use it for?
We use it to break up secretions in the lungs.
Yeah, so we use it as a mucolytic, where basically they would inhale the drug and actually can break down mucus. So sometimes we use it for like CF patients. Sometimes we'll use it for anyone who's really kind of just junky, nasty secretions in their lungs, right? I use it a lot for Tylenol overdose. That's kind of the antidote for Tylenol overdose. If you had someone who took way too much Tylenol, you give them N-acetylcysteine. The other thing you can actually do is use this as a renal protective agent. And so what we'll do sometimes for patients who have high risk for acute kidney injury, especially if they're getting something like CT scan or they're getting contrast agents, we can sometimes give this to them before and after the procedure to try to protect the kidneys a little bit. Again, not a great amount of evidence to say yes, this is 100% effective, but most nephrologists I know have used it from time to time, so they think it's somewhat effective. And again, so low cost, low side effects sort of thing, you can always try it. And I'm sure you smelled the Mucomyst. It smells pretty gross, right? So it smells like rotten eggs because of the high sulfur content. And that's what helps with that free radical scavenging effect there. Okay. So as far as treatment goes, obviously we want to try to get rid of whatever the insult is, try to get rid of whatever actually caused the kidney injury in the first place. If you can discontinue the medication, that's a good thing. And the supportive care is one of the big ones you can do. So just try to make sure you monitor their fluid status. If they are fluid overloaded, try to give them loop diuretics. If they are dehydrated, give them fluids, whatever you have to do to support them through that. And then occasionally we'll give them renal replacement therapy. If they are needing an artificial means to clear a lot of the waste products from the blood, we can do this. And I'll talk about this a little bit more. I'm not sure if the next slide or not, but we'll look at that in a second. And then typically, if you can kind of reverse it, if it's kind of a short injury that has occurred, you can get recovery of normal function within, say, 10 to 14 days or so. But again, you want to minimize that insult as best you can, try to reduce any of those kind of extra renal complications like hyperkalemia or any other kind of issues with that, and try to help to kind of expedite that recovery there. So I think I have another slide later on that talks about different types of renal replacement therapy, so we'll talk about that when we get to it. So again, when you're looking at dehydration, make sure that we always try to replete orally whenever possible if they can tolerate it, right? So we want to not just give free water all the time. Sometimes we want to make sure to have something with some electrolytes in it, something like a Pediasure or something like that. Gatorade itself doesn't really have enough electrolytes in it, but something like a Pediasure is good. And then if you need IV fluids, so if they need a really kind of a big dose to replete them, or if they're not able to tolerate oral, this is where you can use IV fluids. And we talked about the dose before, I know, that in general, for most adult patients, 1 to 2 liters is usually pretty good. And then if you need like an actual ml per kilo dose, 20 mLs per kilo is the way to go, right? That's what we do for kids. Now, if they had, chronic kidney disease, or if they had CHF and they already had a lot of edema, and this was something where maybe you want to cut that in half. Maybe you say half a liter, or use 10 mLs per kilo, and then you can monitor them. You can see how they're doing and then reassess, right? You can always give more. You can't take it back once you give it, right? And ideally, you're monitoring for things like their mean arterial pressure. You guys familiar with that term? I don't know what that is. So that's exactly what it says, mean arterial pressure. Basically, it is another thing you're going to look at. And so if you imagine the blood pressure is about 1/3 of the time is in systole, and about 2/3 of the time is in diastole, right? Just based on the way the heart pumps, and you kind of theoretically make sense of that. Basically, if you took 1/3 of the systolic and put it with 2/3 of the diastolic, you basically get your mean arterial pressure. That's how it's calculated. You usually see it on the monitors. So usually 65 is considered pretty good. That usually means you have enough pressure to perfuse most of the organs there, and that's what we shoot for. Or you can also look at the urine output. As long as it's greater than 0.5 ml per kilo per hour, that's usually a pretty good sign that kidneys are being perfused, and they should be producing urine, right? And you're just looking for edema, looking for electrolyte imbalances, normal glycemia as well. Again, if you're constantly pumping someone full of normal saline, they can get hypoglycemic, so you may need to do NS and D5 or something like that. So a common combination we'll use there. So again, I mentioned for anuric or oliguric patients, use less, 250 to 500 mLs or so. And then watch out for patients with CHF or pulmonary insufficiency. They tend to hold on to this fluid a little bit more there. Don't really worry about this part so much. Just know that if you give huge doses of sodium chloride, they can accumulate that chloride quite a bit. So again, normal sodium, you guys know what that is? Yeah, 135 to 145. What's a normal chloride? Usually in the 110-ish area, maybe 110, 115, something around there. Again, we mentioned that normal saline is 154 milliequivalents per liter of sodium, which is pretty close to 135 to 145, but is significantly higher than what your normal chloride is, because again, it's 154 of chloride as well. So you can see them get too much chloride and they get actually acidotic from that. So again, not something that happens too commonly, but if you give a huge dose, especially in like septic patients, you may see that occasionally. And then obviously if they are, their hemoglobin is low, then you want to replace blood, especially if they have any kind of bleeding or whatever led them to become, having a low hemoglobin in the first place. So looking at renal replacement therapy, so you can sometimes do what we call intermittent renal replacement therapy, or you can do continuous. And so depending on the type of patient you're dealing with, if it's like a chronic kidney disease patient, they may be on Monday, Wednesday, Friday dialysis, right? They'll go in usually for 4 hours. They'll be hooked up to a machine. Basically, there's an arterial and a venous side of the machine, and we'll go through and circulate all the blood out of the patient, not all at the same time. That would be bad for the patient, right? And then it will circulate out. It has basically a filter that will get rid of a lot of the waste products and then put it back into the patient, right? So nice new clean blood for them, and they get rid of all the waste products. And usually 3 times a week is usually pretty good for them. We have a lot of patients who show up to the ED though that usually like on a Sunday or a Monday, and they're like, I missed my dialysis on Friday. for whatever life happens, and so they end up getting hyperkalemia. Their K comes back at 7. They're fluid overloaded. They're in really bad shape, so they come to the ER for dialysis, which is not ideal. But in other cases, we may do like continuous, where basically you're just on a machine that's basically just replacing your kidney for that period of time. It's usually up in the ICUs and things like that. We use it. And just an idea of when you can use dialysis is kind of an easy mnemonic to remember common reasons why you use hemodialysis. Things like acid-base abnormalities, so you just use your vowels here. Acid-base abnormalities, because you can correct things like acidemia very quickly. Usually that's some of the more common causes. They're acidotic, you can replace that very quickly. They have an electrolyte imbalance, because you can pull off excess of potassium and magnesium, things like that. Intoxications, so we'll use this occasionally for some drug overdoses. So if I had a patient who had a lithium overdose, or if they had, say for instance, I'm trying to think of another good one off the top of my head, they drank a bunch of radiator fluid, you could pull it off with that. So lots of different reasons why you might use it for tox stuff. And obviously fluid overload, you can pull off excess fluid, right? So you can not put all that volume back in the patient, but you can pull off some of it. And then also uremia. So they're getting to have that kidney injury, they're holding on too much uric acid, that will also pull it off as well. So those are common reasons why you'd use hemodialysis for these type of patients. Again, looking at hemodialysis, obviously this is going to be where they're actually taking blood out of the venous side and pumping it, out of the arterial side and pumping it back into the venous side. You usually have a dialyzer, which is that filter. I guess covered this at all yet? You'll probably get more detail on it, but I'm just kind of getting a brief overview. This is nice because you'll find that certain drugs will have special dosing for hemodialysis. So you can get them almost relatively normal therapeutic doses to get the same effect, but you're able to clear it out of the dialyzer and then make sure they're dosing appropriately, because otherwise they end up holding on to it. And then there's peritoneal dialysis. This is where actually a more interesting one, where they'll actually take this fluid, they'll put it into the peritoneal space, and they will kind of let it sit there for a while. And then while that kind of the waste products kind of re-equilibrate out into this new fluid, then they can pull it back out and get rid of all the waste products. So it's not like they're kind of making urine in this peritoneal space and they yank it back out. I see a lot of patients get infections, peritoneal infections here, that can be a little bit more difficult to treat. But they'll do these exchanges where they'll put the fluid in, wait 20-30 minutes, take it back out, put new fluid in, and basically they can clear the blood that way. So some patients will be on hemodialysis, some will be on peritoneal, it just depends. All right, so when dealing with a patient with acute kidney injury, some of the things you have to consider as far as the other medications that they're on are things like volume distribution. So for instance, if you have a patient who's holding on to a ton of fluids, they get very edematous. What do you think that does for hydrophilic medications? What do you think the volume distribution would do? Go up or down? Should go up, right? Because they're diffusing out into all this extra space, right? On the other hand, if they were fluid depleted, you may see they would have a decreased volume distribution because they're all getting concentrated into the blood, right? So you have to think about things like that. They're actually getting to the sites where they're supposed to be working. The volume status of the patient kind of goes along hand in hand with that. And then also looking at the antibiotics in septic patients. So for instance, if they have really poor kidney function, maybe something like vancomycin isn't the best option. Maybe I could use an alternative if I was trying to treat like an MRSA. You guys remember the one that you could use that did not rely on kidney elimination? Another MRSA active drug? Or linezolid or Zyvox, that's like a decent alternative. So you could potentially use that instead if that was a concern. Otherwise, you have to make sure you're adjusting the doses appropriately, whether you're giving the drug less frequently or changing the dose, whatever happens to you. Make sure you look that stuff up prior to prescribing, because otherwise you can hold on to too much and see some issues there. Now, as far as actual medications to treat acute kidney injury, there's nothing that's going to reverse the problem, right? So you really need to make sure you're getting rid of those kind of causative agents. But you can use drugs to help to manage the complications of acute kidney injury. So we'll talk about these a little bit more. So first off, looking at diuretics you can use. So sometimes we can use osmotic diuretics to help get rid of some of those extra fluids. I mentioned mannitol before. This is one we use more often than not. We use it for cases where patients have cerebral edema. So this is very good because you're giving a very hyperosmotic sort of product. This helps to draw water out of the brain, which can be very useful for that. So this is probably the more common place you'll see it being used for like head injuries, like in trauma centers, things like that. Now, this can actually cause acute kidney injury itself, so it's not used very often for this purpose, but I just kind of want to mention it here again. But it has to be filtered. Does anyone know why it has to be filtered? It has a tendency to do this little thing where it crystallizes. And if you imagine hospitals, they normally get pretty cold or pretty warm? Pretty cold, right? Because we don't want bacteria to grow as best we can. So you see this crystallization of it. So imagine putting that into your patient. not good. So usually places will have like mannitol warmers that will keep it nice and warm and in solution, and then you filter it as well to make sure none of those crystals get into your patient, cause an embolus or something like that. So you can also use loop diuretics. These are more commonly used. We know they're very potent diuretics. They're well tolerated, pretty cheap. Watch out for sulfa allergies. You may want to use ethacronic acid as an alternative for those patients, right? That's kind of the one main place we use ethacronic acid most often. Now, loop diuretics, you can end up running into what we call loop resistance. I know I've mentioned this before, but basically what you end up having is that loop diuretics obviously work where in the nephron. Where do loop diuretics work in the nephron? In the loop of Henle, right? What comes after the loop of Henle? So remember, the loops work on the ascending portion of the loop of Henle, then it goes into the distal convoluted tubule. Does anyone remember what diuretics work there? Thiazides, yeah. So thiazides work in the distal convoluted tubule. So as you can find with people who are on loop diuretics pretty chronically, they can end up having this resistance where the distal convoluted tubule tries to pick up the slack and will reabsorb a lot more sodium. So it looks like your loops are getting less effective when really it's that distal convoluted tubule trying to working in overdrive. And so sometimes what we'll do is we'll actually give a low dose thiazide along with a loop diuretic, and will help them to maintain their urine output. Now remember, as kidney function gets worse, thiazides tend to work less effectively, right? So remember, there's one thiazide that you can give for patients with really poor kidney function, especially like a creatinine clearance less than 30. That's where you can use something like metolazones. That's really the good one to use for those patients. So you give them a loop diuretic, give them metolazone, and they'll pee like crazy. You don't have any problems with that. Let's see. So again, some things you can add on. Chlorothiazide's a fine one. HCTZ could work as well, but then metolazone's going to be good for those patients with low GFR. Occasionally, you can also use other agents that kind of work further along, usually in collecting ducts. So you can use like a loop potassium-sparing diuretic or an aldosterone antagonist, but more often than not, a thiazide will work just fine for that purpose. Okay, so for electrolyte management, obviously they can get hypernatremia. So one of the things you can do is try to limit their sodium intake, right? So there's less sodium coming in. That may cause loop diuretics to work a little less effectively because less sodium in the getting filtered in the nephron, the less likely the sodium loop diuretics work. Because again, they're working on that reabsorption of sodium and blocking that. So that can be one thing you run into. But mainly, if they're hypernatremic, hold off on how much sodium they're getting into their diet. That can be one thing. Of course, renal replacement therapy like dialysis can pull off that extra sodium, so that may be one thing to do. And then obviously hyperkalemia can be another big one. Again, dialysis can fix that, but in cases that you can find kidney patients where they miss dialysis or something, their K will go up, 6, 7, and they're very much at risk for arrhythmia, so you got to watch out for that. Now, you got to watch out with phosphorus and magnesium. They tend to not be removed by renal replacement therapy very well, and these are some cases where you may see it start to build up. So especially breakdown of muscle tissue, trauma, etc., where you can have a buildup of magnesium and phosphorus. You want to avoid calcium. The reason for that is calcium and phosphorus like to bind together at high concentrations. If you have a very high phosphorus and high calcium, they'll bind up together and they will precipitate out. Is that going to be a problem where you can have an embolus form? They can crystallize out in the tissue. Not good. So you want to be careful with that. And another really important point here is that when you have the blood being circulated out of the body, what do you have to make sure it doesn't do in all that plastic circuit of the dialyzer machine? Because again, it's running through plastic tubes. So you want to make sure it doesn't clot off, right? So we actually use an anticoagulant in the dialysis line called citrate. Use citrate that will actually bind up calcium. And because if you go back and look at your clotting cascade, calcium is really important for kicking that off. No calcium, not going to clot off in the line preferentially. But when you put it back into the patient, all that calcium is not there. So you run the risk of them becoming hypocalcemic, so you may need to replace that, right? So it's a specific concern for patients who are getting dialysis that have that citrate anticoagulant. That make sense? So you're binding it all up because it's in the dialyzer to try to prevent clotting. Put it back in the patient, you need to replace that calcium. Yes?
Is that something that you have to do labs to find out how much they lost, or is there a basic give patients this afterwards?
Yes. You can do both, right? So you can monitor labs.
What are we going to see in the field?
You usually what you'll find is that they may have standing orders set up, like PRN for ionized calcium less than 1 or something like that, to where the nurses can monitor the labs, and because sometimes you have like nursing-based electrolyte protocols, especially for patients like that, where if their calcium is low, they have a PRN order they can just put in and they can get it replaced essentially. In some cases, you may see them will give some calcium, but maybe not a ton. Just because you want to make sure, because those kidney patients have problems getting rid of calcium in the first place, so you don't want to get it too high and cause issues with that phosphorus. Yep. Okay, so that's basically the gist on acute kidney injury. Getting into chronic kidney disease, this is where there's going to be a lot more medications involved with this. We'll talk about here. So obviously, the staging of chronic kidney disease is generally based on the GFR. I'm not going to ask you specifically. Patient creatinine clearance is 30. What is their stage of chronic kidney disease? But just know that as it gets lower, they have worse and worse kidney function until eventually they have ESRD, which stands for end-stage renal disease. So that's not good. This is usually where we consider dialysis and whatnot to put them on to replace that kidney function because they can't get rid of their own waste products already. So there's lots of complications with it as the kidneys get more and more damaged. One thing you can see them more likely to bleed, right? So they tend to have these bleeding diatheses. You can have some platelet dysfunction that can occur. Usually this comes from having uremia and not being able to clear those waste products. You also see that insulin is actually released through the kidneys, gets eliminated partially through the kidneys. Hold on to more insulin, more likely to see hypoglycemia. So that can be a risk for those patients. And then also GI bleeding, delayed gastric emptying, and then also neurologic complications like encephalopathies and neuropathies can occur. So lots of problems from having this kind of chronically high levels of these waste products that are not being cleared by the kidneys. So usually we're going to see a leading cause is going to be diabetes. So long-standing diabetic patients tend to have that kind of microvascular complications of kidney disease, hypertension, glomerulonephritis. Those are probably the common ones. Other things that can help to progress kidney disease, chronic kidney diseases like hypertension, smoking, obesity, proteinuria, all those can just worsen over the long term. So what we're seeing is that, and when do you typically see, because we have two kidneys, right? So we have a lot of extra reserve potential there. So really, you don't start to see things like changes in creatinine clearance until you've lost a significant amount of kidney function. And that's kind of a problem because we can't really catch it early enough in a lot of those cases. So this is why you have to look at those patients like, okay, I know you're diabetic. I know you're at high risk. Let's start to try to work with this early rather than waiting until we actually see the creatinine clearance go down. You remember what drug you want to put diabetics on to save the kidneys? ACE inhibitors or ARBs, right? Because it's going to be really important to prevent that remodeling that occurs over time, where they lose a lot of nephron mass and all of that. So, and again, what you're going to find, especially with like hypertensive patients, is that it's kind of a sick cycle here, where again, when you have the kidneys sensing that there's low pressure, there's low blood flow, that activates the renin-angiotensin system. And what does that do to the blood pressure? Makes it go up, right? And that's going to make it kidney blood flow even worse. And you start to see how kind of a sick cycle, how all these kind of changes that occur over time, to where again they're just all going to cause this progression of kidney disease. So again, you want to fix the hypertension, you want to fix the diabetes, you want to fix all these chronic problems to help prevent progression of that disease into chronic kidney disease for those patients. So other big problems you run into, other things you might not think about when you think about chronic kidney disease, you can see anemia. And that's mainly because a lot of erythropoietin gets formed in the kidneys. About 90% of that production happens there. And so you lose that. And so you end up getting this normochromic and normocytic anemia, where the red blood cells are relatively normal. The hemoglobin production is normal. The problem is you just don't have enough stimulus from the kidneys to actually stimulate those new red blood cells to be formed, right? So that's one thing to consider there. Also, you end up running into a lot of iron deficiency as well. So one, if you have frequent blood testing or if you're losing blood in the circuit from the renal replacement therapy, the dialysis, you can end up having iron deficiency, related anemia there. They have decreased GI uptake. They tend not to absorb as much from the GI tract. And so also they're going to have increased iron demands because they're, especially if you're going to give them erythropoietin to try to replace the red blood cells and the hemoglobin they're not producing on their own, right? So iron is a really important thing. Anytime you're giving a patient erythropoietin, you need to make sure they're getting iron as well because it's super, super important for that hemoglobin formation. So you can also run into these mineral and bone disorders. So you see issues where the parathyroid, have you guys covered anything with the parathyroid yet? What does the parathyroid do? Regulates calcium, regulates vitamin D. Phosphate is going to be somewhat important with that as well. And so what you're going to find in those patients is they tend to have a hyperactive parathyroid. We'll talk more about that in a few seconds. They're going to have issues with calcium and phosphorus. And again, especially if those levels start to increase, and we have what we call a calcium phosphate product. We actually just multiply the levels together. And if it's too high, that shows you patients more likely to see that crystallization occur here. They also tend to have poor vitamin D synthesis. Anyone know where vitamin D is made in the body? Starts out, it's a multi-step process. It starts out, with sun exposure or a dietary intake. That's not active vitamin D though. It's going to be a multi-step process. The liver is going to be really important here, and the kidneys are going to be the final step. So again, if you have bad kidneys, guess what? you're not making vitamin D active form very easily. So we'll talk about that as well. They're also going to have a lot of bone turnover, and so you can see this osteomalacia, osteoporosis that can happen with these patients, and then all that calcium gets calcified out in the tissue. So and it's kind of culminates in what we call renal osteodystrophy, and we'll talk about that a little bit later. So looking at this issue, so decreased renal function, they're going to find that they cannot clear phosphate very well. So they're going to have increased phosphate levels, which binds up calcium. So they end up having hypocalcemia. The parathyroid picks that up and they say, hey, we don't have enough calcium around here. Let's go ahead and if the body senses there's not enough calcium, where does it get that calcium from? The bones, right? So it's going to say, hey, let's increase osteoclast activity. Let's go ahead and increase the activity of those cells to try to liberate some of the calcium from the bone. So you can start to see where that the bone dysfunction comes from already. But basically, they're going to start to increase calcium release from the bone, also increase calcium reabsorption from the kidneys as well. To try that, and you're going to see more phosphate. So, and not only that, but because we have less vitamin D being produced in the kidneys, that also will signal the parathyroid to increase more PTH secretion, right? Parathyroid hormone. So again, there's going to be a multifactorial problem here, and this is where you're starting to see where a lot of these meds are needed to replace a lot of this. So, again, I'm not going to get super into detail on this. Just know that as a patient, has all that calcium and phosphate in the system, all that binds up, the parathyroid is just going to be overactive. It's just going to be sensing there's not enough calcium, there's not enough vitamin D. I need to be overactive, and it's going to lead to further and further bone degradation, osteomalacia, osteoporosis that can happen. So again, a lot of our drugs are going to be focused on trying to prevent these complications from happening here. And again, if you look at a patient who's on dialysis, their med list is usually a mile long in a lot of cases because of all these problems we're having to fix here. So again, we're going to see that parathyroid hyperplasia is where we have what we call osteitis fibrosis cystica, where we have that really high bone turnover due to the increased osteoclast activity, where you can see decreased erythropoiesis as well, and osteomalacia happens here. So other things we can see, some signs and symptoms associated with chronic kidney disease. When you have high urea, you're going to see a lot of issues with this, like fatigue and weakness. You're going to also end up seeing a lot of these peripheral neuropathies that can happen here. And then obviously, as far as their fluid issues, they're holding on to a lot of fluid. You're going to see edema. May have poor urine output, and also, especially with poor kidney function, the glomerulus isn't really working that well. You see this foaming of the urines, which is indicative of proteinuria. So if you're spilling a lot of protein into the urine, you see it get very kind of foamy. It could be one of the signs I'll notice there. So what we want to do for these patients, again, I'm trying to get to the drug therapy because again, I have a lot of slides to get through. We only have 2 classes left. But we want to prevent progression of disease wherever we can. We want to minimize the severity of the complications that happen with these patients, and then limit the need for hemodialysis, peritoneal dialysis, or transplant. Ultimately, we can do a transplant, give them good functioning kidneys, but we want to prevent that from occurring if possible, right? So trying to slow the progression, try to save as much kidney function as we can, and address any other primary problems like diabetes or hypertension, whatever it happens to be. So looking at non-pharmacologic therapy, you want to make sure these patients are keeping a low protein intake, so less than 0.8 grams per kilo per day, especially if their GFR is less than 30 mLs per minute. That way they're not having extra protein they're having to filter and it spills into the urine. You also want to limit their sodium intake because they tend to be hypernatremic. Okay, so those are big things. Exercise, smoking obviously is going to go a long way to help these patients as well. Now, for patients with diabetes and chronic kidney disease, they absolutely need to be on an ACE inhibitor, or if not, an ARB, because we know this helps to prevent a lot of the kidney remodeling that happens there. But you have to consider, we said the potassium does what in patients with kidney disease? Goes up or down? Goes up. What does ACE inhibitors do to potassium? Goes up, right? Because they're inhibiting aldosterone. Aldosterone holds on to more potassium. So again, you can see synergistic effects here where they can get a very high potassium if you're not careful. So you got to watch out for that. Another thing, we haven't talked about diabetes yet, but a common drug we use for those patients is called metformin. You need to watch renal function for that as well. If it gets down too low, they can end up holding on to too much metformin, and that can actually cause potentially fatal lactic acidosis. We'll talk more about that when we get to endocrine in the next semester. So typically for hypertension, we want to make sure we get the patient's blood pressure. Usually the goal is around 140/90. You end up seeing significant, if they have a lot of protein spillage, they have a lot of albumins being released through the kidneys, you want to maybe shoot for a little bit lower than that, but usually 140/90 is usually pretty good. Really, if they have diabetes, ACE inhibitor and ARB should be first line for them. Usually a thiazide diuretic won't be sufficient to get their blood pressure under control. And again, you're going to be monitoring other factors. So they have an MI, they probably need to be on a beta blocker. They have CHF, probably a beta blocker, whatever other meds they need to be on as well. So always consider their other comorbidities when deciding what kind of drug is best for them. So looking at the anemia of chronic kidney disease, obviously we want to make sure we're increasing our oxygen carrying capacity, because obviously one of the big signs of anemia for these patients is going to be what? If you have low hemoglobin, what's a common sign of that? Yeah, fatigue is a really big one, right? Because again, you can't oxygenate the body appropriately. So we want to decrease the signs and symptoms and try to decrease the need for transfusions, right? So again, if we can have the patient make their own blood, that's always going to be preferential to us giving them someone else's blood, right? Anyone know who can't receive other people's blood? It's a certain religious organization. Yeah, Jehovah's Witnesses. Yeah, they have they cannot receive other people's blood. This is one of the more common ones we'll run into from the pharmacy side. I'm sure, like in surgery and other things, they have lots of other issues. There's like other things, but yeah, even some of them are actually worried about getting erythropoietin, which is we'll see is one of the drugs. It's actually recombinantly formed. Erythropoietin actually never came from a person, and they still get really kind of iffy about even receiving that because they're so worried about the blood issue, which is kind of interesting. So again, you'll run into those kind of patients where like, okay, well, this blocks off one whole treatment modality. You got to figure out what to do to make sure I'm still treating them appropriately as best I can. But anyway, what we're going to do for those patients, again, avoiding giving them someone else's blood, we're going to give them an erythropoiesis stimulating agent, or an ESA. You might see that being abbreviated, and then iron supplementation. Now, obviously, for monitoring, you're just looking at the hemoglobin most often. So, question is, how much is a good hemoglobin, right? You cannot look for shooting, you can't really shoot for normal hemoglobin concentration for these patients. What you find is that as you stimulate the blood cell production, stimulate hemoglobin, what do you think that does to the viscosity of the blood? Usually makes it thicker, right? So the concern is if you try to shoot for too high, you can end up having the sludging of the blood that occurs where they can see increased risk for stroke, MI, all kinds of things like that. And there's actually a black box warning on that to not get their hemoglobin too high. So this is a super, super important point where we'll probably start considering erythropoietin for patients who have a hemoglobin, say, between 9 and 10, and we're going to shoot when they start to get above 10, usually 11, a little bit higher for our renal replacement patients because they're usually losing a lot of blood due to labs and dialysis and whatnot. And so what they find is if you keep the hemoglobin above 13 grams per deciliter, which could be normal for a lot of your patients, that's actually increased mortality. There's a black box warning. You don't want to do it. It's an easy way to get sued if you were to treat that inappropriately. Keep in mind, you can give them as much erythropoietin as you want. If they do not have the hemoglobin or they don't have the iron stores to make the hemoglobin, it's never going to go up. So you really need to make sure you're supplementing where appropriate. So we have a couple of different ones. You have things like epoetin alpha. So if you see Epogen or Procrit, these are ones we use. You have darbepoetin or Aranesp, was the two most common ones. But just remember this risk for death, MI, stroke, venous thromboembolism. All of that comes back from that risk of getting the hemoglobin too high, right? That's kind of a relative contraindication there. There is some risk for some cancers, but again, not nearly as prominent as that risk for clots. Usually you can dose it either several times a week, or in some cases you may give it every 4 weeks or so. So again, usually they'll come in, get their dialysis, and they'll get the epoetin at the same time. That way they can kind of get it all in kind of one-stop shop. But as you might imagine, issues of adverse effects include things like hypertension, vascular access thrombosis. Those are kind of the more common things you worry about in patients receiving EPO. Otherwise, they're very well tolerated. Then I mentioned the iron status is really important, so you want to make sure that if they're getting EPO, they probably need to be getting iron. There's a very rare patient that would ever need EPO by itself. No one has that good iron stores for the most part. So you want to make sure they're getting good dietary intake. You want to make sure they're getting good B12 and folate, because that's really important for hemoglobin synthesis as well. Again, typically you may find that oral intake's not good enough, right? So they're taking the oral stuff, but they may not have really good GI uptake. So instead, we can give them actually IV iron as an alternative. So we have a couple ones. We have oral preparations. There's several different salts: ferrous sulfate, ferrous gluconate, ferrous fumarate. Really make sure you're looking at the elemental content of the product. Nowadays, they're a lot better about saying what the actual elemental iron content is, because again, 325 milligrams of ferrous sulfate does not have the same amount of elemental iron as 325 milligrams of ferrous gluconate, right? The salts are different. The actual milligram amount changes. So you got to look at that elemental iron content. And we have a couple of IV preparations. We have things like iron dextran, sodium ferric gluconate, iron sucrose, and sphero-moxetil. Probably the more common one I see is Sodium ferric gluconate is probably the more common one, and then iron sucrose. These are kind of the two most common ones we use. We use a lot of iron sucrose for our anemic patients over at Nemours, probably the more common one. You guys remember any side effects from using oral iron? Constipation, and what else? Is it turning anything a different color? Make your stools black. So watch out for that, because again, you think dark stools, you think GI bleed. It's not the case. It's just iron. A lot of times they're making the stool darker. Good. So I mentioned constipation is a big one. A lot of patients are going to have GI upset with this, so you just need to find the right kind of product that is going to be most tolerable by them. And then with the IV formulations, we have to watch out for things like allergic reactions and things that kind of mimic that, so like hypotension, dizziness, headaches. So we typically try to infuse that as a slow infusion over a couple of hours. That usually kind of limits a lot of that hypotension you see with that. And they're pretty expensive, so if you can get away with oral supplementation, that's great. IV stuff is very, very expensive in comparison. Okay. Mentioned, fewer side effects, usually cheaper for oral. And then a lot of times if they're renal replacement therapy or hemodialysis patients, they're going to need IV in order to replace that. And so typically you're going to monitor their iron status every 3 months or so while they're on erythropoietin or some sort of erythropoietin stimulating agent. And then they're going to be monthly after that, usually if you're titrating your dose or so. And then monitoring the hemoglobin at least every 3 months, but if they're on dialysis, you need to be much more frequent than that, because again, you're taking a lot of blood out of them when you're running the dialysis on them, essentially. Okay. And then looking at treating the mineral and bone disorder. So again, here we want to make sure we try to minimize the amount of bone degradations happening over time. We want to minimize that rapid turnover. We want to get our vitamin D levels supplemented. We want to make sure calcium and phosphate are in good levels. And we want to make sure that our PTH is not kind of going in overdrive. Okay, so we have several drugs that do that. Typically what we like to do is we like to keep our calcium phosphate probably less than 55. Again, that's just multiplying calcium and phosphate together. If it's more than 55, you need to get rid of either one or the other, okay? Because they're more at risk to cause that precipitation that can occur there. And then also we're going to monitor our PTH levels. So one of the things we can do is from a non-pharmacologic standpoint, you want to limit phosphate intake. Less phosphate coming in through the diet, the less phosphate that you have to worry about getting rid of from the blood. And so this is one of the big ones. Things that you may not know that have high phosphate contents, things like meats, things like dairy products, peanut butter, and then a lot of sodas, especially like dark sodas and things like that have a lot of phosphate in beer. So again, I would be very, very distraught if I had chronic kidney disease, because this would take out like 90% of my diet. But again, typically you're going to also find they have very low protein requirements as well. So, you don't want to give them too much protein, but you will find that especially if they're on dialysis, they have a higher requirement, because again, they're just kind of more metabolically active. They need to get a little bit more protein to make sure they keep their muscle mass essentially. Now, in general, you're going to find that dialysis is not going to be good enough to really get rid of that phosphate. So you're going to have to use something else in order to try to get rid of that. So we'll talk about some phosphate binders in just a few minutes here. And then you might find even some patients will have a parathyroidectomy if they cannot get everything under control otherwise. So there's a couple of phosphate binders. Here's the ones we're going to use most commonly. I'll talk about these more in detail here, but notice here calcium carbonate is probably going to be the cheapest and easiest one. We talked about this before, right? Where we see this being used for? Yeah, Tums used for? Yeah, for GERD. Yeah, if it's an antacid, perfect. And then we also have drugs like calcium acetate. So again, we mentioned calcium binds phosphate in the blood. Guess what? We can do the same thing in the GI tract, right? So calcium can bind up phosphate there and prevent us from absorbing it in the first place. That can be really good. Also have a couple other ones like sevelamer carbonate, lanthanum carbonate, and then also aluminum hydroxide. We talked about that one as well as being an antacid, usually used with something like magnesium hydroxide or something. That way we'll end up, because we'll look at the diarrhea constipation issue in just a second here. So typically, we're going to find that a lot of our patients, especially in early chronic kidney disease, tend to be hypocalcemic. And a lot of that can be due to the high phosphate kind of binding up the calcium here. And so this can be useful to use something like calcium carbonate, because you may actually get a little bit more calcium, and you give it prior to meals, so that way it can kind of interact with the food, try to bind up phosphate, and then eliminate it to the GI tract. Sevelamer is just kind of this hydrogel that forms that can have some negative effects, or actually have some decent effects on your lipids here. You can see lowers the LDL, raises the HDL. Again, usually calcium carbonate, pretty cheap, easy to use up front. As that starts to fail, you can use things like sevelamer. And then you're going to see the aluminum we don't like to use very, very often because as patients are on this chronically, they tend to accumulate aluminum because their kidneys are bad, they can't clear it, and that causes neurotoxicity. So it's kind of a last line agent. If they couldn't receive other ones, they would use aluminum instead. All right. So typically, a lot of it's going to be GI effects because, again, that's where they're working primarily. So a lot of constipation, diarrhea potentially. Hypercalcemia if you're using calcium-based products like calcium acetate or calcium carbonate. And then I mentioned that aluminum toxicity there as well. Be aware that you're going to see a lot of drug-food interactions with this because we're giving calcium. It's going to bind up other things as well. So imagine, if they get an infection, because we find that kidney disease patients tend to have a higher risk for infection, they need a fluoroquinolone. They're going to get levofloxacin. That can bind up with calcium, right? Also, what else did I mention they should be taking for their hemoglobin? Iron, right? That can bind up with a ton of stuff as well. So you have to be really careful with that. Make sure you're separating things out either 1 hour before or 3 hours after. Okay, so they also need vitamin D. So typically you're going to find that most vitamin D preparations are out there either going to be ergocalciferol or cholecalciferol. It's vitamin D2 and D3 respectively. Obviously we make some vitamin D on our own, usually in response to UV exposure. So typically, unless you are like me and you're very pale and like to stay inside all the time, you may not get a lot of vitamin D. But being a good Floridian, go out there and get some sunlight. Anyway, the problem is that it's kind of a two-step activation. So even the stuff we make in the skin isn't physiologically active yet. It has to go in the liver to get hydroxylated, and then finally to the kidneys to get the second hydroxylation. So the active form is 125 vitamin D3. Okay, this is the active form. If you have chronic kidney disease, you cannot make this product yourself, very well at least. So we're going to give a drug called calcitriol or rocatrol, which is the active form. Obviously, it's much more expensive, but if you can't produce it on your own, you have to give something. Okay, so you can give them all the cholecalciferol you wanted. You can have them eat all the eggs you wanted and nuts and things like that are high in vitamin D. It doesn't do them any good, right? They need to have the active form already. And this also will help to stimulate the parathyroid. It'll say, hey, there's enough vitamin D here. I don't need to hold on to as much calcium. I don't need to get as much calcium from the bone. That can be a very positive stimulus there. We also will have a drug called paracalcitrol. This is going to be activating PTH receptors, but it's nice because it doesn't actually affect calcium and phosphate absorption. Basically kind of tricks the parathyroid into thinking, hey, things are all good here, stop this reabsorption activity at the bone. So that may be another drug you'll see them on occasionally. Okay. Next, we have cinacalcet. This is going to be sensitizing parathyroid receptors. It actually makes it more responsive to calcium. The calcium is there, so that way it can help to reduce PTH secretions because if it thinks there's enough calcium, it's not going to release as much PTH. You're not going to have as much bone degradation happening. So that can be very useful for patients who are still having kind of these electrolyte abnormalities. Okay, so those are the main meds you'll see being used for chronic kidney disease. So again, have a chronic kidney disease patient who's on dialysis 3 times a week. They could be on erythropoietin. They could be on iron. They could be on calcium acetate. They could be on an ACE inhibitor. They could be on something else, say a beta blocker. See how the med list can start to kind of propagate and can become quite extensive. So med history is super, super important just to make sure. Although honestly, a lot of these patients I'll see in the ICU, I don't think you can actually kill these patients. So if if the bomb drops, there'll be cockroaches left over and dialysis patients. For whatever reason, they get so sick they never die. They just live forever apparently. So good on them. Hopefully someone can still run their dialysis then, but we'll see. Okay, so just briefly we'll cover drug-induced kidney injury. I might actually get done on time. That's be great. So some manifestations, some things you can see when you have drug-induced kidney injury. So you can see acid-base abnormalities. Typically acidosis occurs in a lot of these patients. Electrolyte imbalances, proteinuria, hematuria. Most common thing you're going to run into is a decreased GFR. This is the most common one. I'm going to hit the drugs that are most commonly associated with causing drug-induced kidney injury. So typically you're going to find that 60% of the in-hospital acute kidney injury that occurs is due to us. The stuff we gave them, including antibiotics, can be NSAIDs, ACE inhibitors. We covered how those cause kidney injury. Remember we said it's pre-renal kidney injury. Chemotherapy drugs and antivirals. These are kind of the more common ones you're going to run into, which we'll talk about here in a few seconds. Now, the most common thing you're going to see, you can see a decrease in your GFR, but we mentioned that takes time to occur because, again, it's directly based on our serum creatinine. You can also find decreases in urine output. It can be very important to monitor for as well because you can see changes happen a little bit more quickly with that one. But certainly, you can see renal tubular dysfunction where you're losing electrolytes, even though the GFR may look okay, which I call those kind of dumb kidneys I mentioned. So again, decreased urine output is going to be one of the first things you're going to see here. You can also see progression to hypertension and volume overload, especially with like chemotherapy, contrast-induced nephropathy, NSAIDs, and the ACE inhibitors. That's what CIN stands for, is contrast-induced nephropathy. We'll talk about here in a few seconds. And again, you can find differences in if you're having a proximal versus a distal tubular injury. Remember that about 50% of all absorption of stuff in the kidney occurs right there in the proximal convoluted tubule. So the damage happens there. This is where you see a lot of more of these electrolyte disturbances versus if it's more in the distal tubule, you see more things like metabolic acidosis due to problems with alkalization that happens in that distal convoluted tubule. So things that can cause acute tubular necrosis, the main ones we'll kind of focus on here, things like aminoglycosides, we've already kind of alluded to, radiographic contrast media, which you'd see using like CT scans and whatnot, cisplatin and carboplatin, these are chemotherapeutic agents. So we'll talk about when we get to chemo next semester, I believe, right? I think so. We didn't talk about it this semester, right? Sometimes my classes bleed over. Like we talked about chemo in the other class, but you guys haven't, so. Anyway, amphotericin B is another one. You guys remember what we use amphotericin B for? I know I've briefly mentioned it before. This would be for fungal infections. We'll talk about that. There's a couple of immunosuppressives like cyclosporin and tacrolimus. These are used often for organ transplants to prevent graft versus host or rejection occurring. And then we obviously have some antivirals here. Pentamidine is sometimes used for treating certain opportunistic infections, and then zoledronate is actually one we use for osteoporosis. These are just some examples. Again, you don't have to memorize this entire list, but we'll talk about specific examples, and I want you to at least focus in on those as we talk about them. So certainly you can find osmotic nephrosis where this can, kind of the injury I mentioned with really hyperosmolar substances like mannitol is a good example of that. It doesn't happen super often, but it's something to consider. And then really look at the hemodynamically mediated kidney injuries. Things that are causing a prerenal kidney injury here, things like NSAIDs, things like ACE inhibitors, even things like cyclosporin and tacrolimus can cause that as well. So some of them can actually pull double duty and perform not even a prerenal, but also kind of an intrinsic kidney injury as well. And then as far as obstructive nephropathy goes, certainly drugs that crystallize out in the tubule can have obstruction. So things like cyclovir, methotrexate, as I mentioned, can do that as well, especially if you don't give it with bicarbonate. Again, by alkalizing urine, you can prevent some of that precipitation with that drug. And then some drugs can precipitate nephrolithiasis, like sulfonamides, like Bactrim, which has sulfamethoxazole and trimethoprim. That's one example. Triamterene and Denavir. This is actually an HIV medication we'll talk about next semester as well. Okay. Some things can cause glomerular disease, things like gold. Anyone know what we use gold products for? For the patients, like really good insurance. Used to be a rheumatologic drug. We used to give gold-based products for that, but we don't use that too often anymore. Really, really toxic stuff. But things like lithium, NSAIDs can also do this. And then some patients may have an allergic interstitial nephritis due to like penicillins or ciprofloxacin. So little things that can cause like more of an immune-mediated kind of reaction here. So again, don't memorize that whole list. These are just examples. Hydralazine, we know that with poor acetylators, slow acetylators, we can see buildup of this drug. You can see like a vasculitis, like a lupus kind of vasculitis that can occur. So you can see that with that one. Even some drug can cause something weird, as like a cholesterol emboli, like warfarin. So again, very rare, but just know that there's lots of different mechanisms that these drugs can induce kidney injury. Okay, so usually they're causing, especially with the acute tubular epithelial damage, these are usually due to direct cellular toxicity, or it could be due to ischemia. So usually one of the two. And you'll typically see the proximal and the distal tubular epithelia takes the biggest hit, right? Loop of Henle usually is going to be relatively spared in a lot of cases. But what you may find is you're going to have sloughing a lot of those basement membranes. You're going to have a lot of cellular debris, kind of muddy brown, kind of granular casts that are indicative of kind of interstitial damage happening. So when you're seeing acute tubular necrosis, the most common presentation is going to be this drug-induced kidney injury, especially in the inpatient setting. The most common ones, and these are the ones we're probably going to focus on here the most likely, are aminoglycosides, by far and away probably the most common one we run into, along with contrast. And then for certain patients, things like cancer patients, cisplatin could be a big one. Amphotericin B, I mentioned, typically used for fungal infections in patients who are immunocompromised, like cancer patients, and then like foscarnet as antiviral, and then osmotic activation. So again, these are the most commonly associated ones. We'll talk about more of these in detail here. Okay, so about 10 to 25% of patients getting aminoglycosides end up developing some sort of acute tubular necrosis from this. So again, why do we keep using these drugs if they're causing all this damage? Usually we've got nothing else, right? So in a lot of cases, either we don't have good alternatives or we can do prospective drug monitoring. This is why we do that therapeutic drug monitoring with aminoglycosides to make sure their levels aren't too high, to make sure they're not going to hold on to the drug and cause damage here. So this is why we monitor for that. Generally, you're going to find that a lot of these patients are typically reversible if you can catch it early and switch them over to something else, right? So maybe, if aminoglycoside is not good, maybe a fluoroquinolone instead, or maybe over to a beta-lactam, whatever it happens to be, something that has similar coverage but without causing this kidney injury. Again, usually this is due to high drug concentration. So if they have poor kidney function due to sepsis or due to chronic kidney disease, these are the things we want to proactively monitor for, so that way we can choose an appropriate dose for them. And so with this drug, you guys remember if it's concentration or time-dependent killer? So it's a concentration-dependent killer. So this is actually a drug we'll give it a really big dose, get the concentration super high, and then we will allow the body to clear it off, and we will change how often we give it based on how well they can clear it. So if someone has really poor kidney function, we'll actually allow them more time to get rid of it. For normal patients, maybe 24 hours. For some of these patients, maybe 36, 48 hours to allow them to clear it. And once they get that low enough trough to show they've gotten rid of it, then we redose them again. So that can be one of the things we'll do as far as monitoring goes. Obviously, the longer they're on it, the bigger the dose they're on. And if they have other nephrotoxins on board, they're more likely to see this develop here. So again, anytime you can eliminate other nephrotoxins, you're going to be better off, right? So if you can't get them off an aminoglycoside, get them off their NSAID or get them off something else they don't need right at that moment, if possible. So in prevention, if you again can use alternatives, great. If not, then you got to use what you got to use, and then limit those concurrent nephrotoxins. And this is where we do a lot of pharmacokinetic monitoring. This is where we're going to be monitoring all those levels. Again, after it gets to steady state, always want to make sure you're doing that, because otherwise you can adjust the dose inappropriately. And as far as treatment goes, if you notice they have drug-induced kidney injury due to aminoglycoside, or you have a strong suspicion it's due to that, then you just discontinue therapy if possible and switch them over to something else if need be. Okay, and then radiographic contrast dye. I don't really talk too much about these agents here, but just know that we've seen a big decline in the number of people who develop this, and a lot of that's due to aggressive hydration. Make sure the kidneys are nice and full of volume, and then also kind of prospectively figuring out like which patients are at risk for developing this, usually by looking at their creatinine beforehand. If they have a really high creatinine, they may not be great candidates to get this contrast, and so you can use like a non-contrast CT or something like that instead in some cases. Just know that you're going to give them a lot of fluids. You're going to give them, usually before the contrast is given, give them vigorous hydration, and then usually for 24 to 40 hours afterwards, continue hydrating for that time frame. And that's usually good enough to kind of prevent the injury from occurring in a lot of cases. So, a lot of this is due to direct cellular toxicity or renal ischemia. That's why it happens there. And the higher the osmolarity of the agent, the more likely they are to see it. And so the other big thing, the big change we've done, is to use lower osmolality agents. So getting closer and closer to isotonic, because again, you run into the same issue here as we did with mannitol being very hyperosmolar. So that's another big thing we've changed in order to make sure that patients not getting such a high osmolarity load, they don't get as much kidney injury due to that. And obviously, they have pre-existing renal disease. These are typically the patients that are going to run into problems. If they already have a creatinine clearance less than 60, they're going to be more likely to develop these injuries. And if they're not really intravascularly repleted, they're dehydrated, they're also going to be at bigger risk as well. And so, again, try to give them as small a dose as possible. We also find that we use non-iodinated contrast studies that can be very useful, or lower isoosmolar contrast. This is the biggest thing we've done to kind of change this. And then obviously give them isotonic crystalloids. If you have time beforehand, to really try to tank them up with fluids, that's great. But sometimes it's an emergent sort of situation. We may not have that much time. Try to give them at least a liter or two, get them full up, and then use the contrast. Some people will try to prevent it by giving things like sodium bicarbonate. This hasn't really been found to be super useful, but on occasion, I've seen mucomist being used here. So we mentioned that previously, where you can give this and it will help to, hopefully deal with those free radicals, deal with those reactive oxygen species. Again, may not have a ton of evidence to show that it's super useful, but it's something we'll do occasionally because it's cheap and relatively safe to do. And if it does occur, if you do have the injury, basically, obviously don't give them any more contrast and just kind of support them through until the kidneys kind of fix themselves. Next up, we have cisplatin nephrotoxicity. So again, this is used very frequently in a lot of solid tumors. We use it occasionally for some of our rhabdomyosarcomas and some of our brain tumors in our patients. The big thing you see with this is a lot of nephrotoxicity. So it's one of the things you're monitoring for those patients. You are going to be hydrating very, very vigorously for that. And one of the problems is you run into a lot of electrolyte issues because as it damages those tubules, they can't really reabsorb electrolytes too well. So you end up losing a lot of magnesium, potassium, calcium. They have all kinds of issues with that. So again, we can try to hydrate very well to try to prevent this. So again, the key here for a lot of these, hydration, 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 if they can tolerate it. So usually we'll try to, again, avoid concurrent nephrotoxins. A lot of this stuff's kind of common sense when you think about it. But whenever possible, we'll try to give this vigorous hydration. We'll give that usually 12 to 24 hours beforehand. There's really rarely cases you have to give emergent cisplatin, so we can try to dose it beforehand. And then, again, keep their urine flow up 3 to 4 liters a day to make sure they're clearing it very well. And then occasionally we'll give this an antidote called amifostine. We'll talk more about this when we get to the chemo section, but just know this is something we can occasionally use. This will actually chelate cisplatin, which will bind it up and prevent it from causing injury. But don't worry about this one so much. Just know that, again, hydration is the key to preventing cisplatin-induced kidney injury. Again, sometimes you may find that once the damage is done, you may have to put them on dialysis intermittently for a period of time. Just depends on how much damage is done, and obviously replace electrolytes as needed. And then we have amphotericin or amphotericin B. I hear a lot of people call it that because it's a very nasty agent. We try to avoid using this whenever possible. But if you have a cancer patient or HIV patient who's immunocompromised, this may be needed to treat some of those really invasive fungal infections. The problem with it is it causes a lot of renal tubular damage. So you lose so much potassium, sodium, magnesium, and you get this renal tubular acidosis that happens here. And so a lot of cases you don't have another drug to really use, which can be kind of problematic. So we actually did a really cool thing where instead of changing the drug, what we actually did is put it into this lipid membrane. So basically this is kind of a lipid bilayer similar to our normal cells, and actually implanted the drug in here. So we call it the ambosome. That's one way we've done that, and actually, for whatever reason, prevents the drug from really accumulating in the renal cells and prevents damage from happening there. So it's again more expensive, something like $1,000 a day versus $5 for the regular amphotericin B. But it is something that where if you prevent someone having to go on dialysis, that can be very much a cost savings in that case, right? And then if you have a patient with intratubular obstruction, this is where we think about things like acyclovir, a lot of our antivirals. Again, hydration is a big thing, potentially sodium bicarb to try to prevent that precipitation from happening there. So typically you're going to see that a lot of times this can either be due to things like tumor lysis syndrome. So I mentioned this is where you have uric acid being released from a lot of those cancerous cells being killed off, and they accumulate in the kidneys. We can actually use allopurinol. Anyone ever heard of that drug? What do we use it for? Yeah, used for gout as well. It actually prevents production of uric acid. That can be something we'll actually give them along with good hydration. And then with rhabdomyolysis, this is actually something where the more common thing you'll see this with is usually like a statin along with a CYP3A4 inhibitor. Look for those drug interactions, try to prevent them occurring beforehand. Let's see. Okay, so that's pretty much it. That's basically going through and saying, okay, how do we treat this kidney injury? How do we prevent it? Obviously, in a lot of cases, you may not be able to prevent it in 100% of the cases, but you try to do the best you can. The main thing is try to be proactive, try to review the patient's med profile, look at their labs beforehand to make sure you're not going to do something that's going to kind of push them over the edge in a lot of those cases. The last section we're going to talk about, I think, is like erectile dysfunction, BPH, and maybe something else, but that'll be the last section, and then that'll be it for the test. So, all right, any questions? Yes, ma'am.
Is there like any type of review?
I don't have one currently planned because we only kind of limited class time, unfortunately. If we finish up early, I can try to do a review if people want to stick around. Any other questions? All right, I will see you guys next time.